Okay, I'd like to welcome everybody to our minimally invasive bone grafting for implant placement webinar today. And I have to say that I'm truly honored to be asked to be part of this expert talk series. And I want to thank Acteon and BioHorizons for the invitation. So, all right, let's get started. So for those who don't know me, my name is Dr. Bart Silverman. I'm a board certified oral and maxillofacial surgeon. I'm also a diplomat of the American Board of Oral Implantology. I practice full-time oral maxillofacial surgery up in New City, New York. That's about 40 minutes north of New York City. I'm also on staff at several dental schools. I'm on staff at New York NYU School of Dentistry, Department of Oral Surgery, Roseman School of Dentistry out in Utah, and also teach the oral surgery residents at Westchester County Medical Center, Department of Oral Surgery too. All right, just love education, love private practice, and we'll get started. All right, so just as far as the disclaimer goes, is that the opinions in this lecture are my own, and in no way have any of the images been altered or manipulated. If there's any company slides in the presentation, they're there because I chose to put them there, and I'm being paid an honorarium for this program, and I do consult for several companies. All right, so what we're going to do today is we have a tall task. So we're going to talk about technology and techniques that will assist us with less traumatic and more predictability with our bone grafts. This starts with atraumatic extractions, and we'll talk about those. We'll also talk about a simple and predictable socket grafting technique. We'll go through some sinus grafting. We'll talk about internal lift or crestal lifts and lateral lifts. And then we'll talk about ridge expansion for some successful implant placement. And at the end, what we'll do is we'll open up for some questions. And periodically, if you want, you can just kind of type some questions, and then we'll take care of those at the end. All right, so what minimally invasive bone grafting starts off with is two very important concepts. So the first is anatomy. And what we need to do is we really need to know the anatomy that in the area that which we work for. You know, several years back when my older son had a sore throat, I remember going to my friend, our physician, and I remember how he said, okay, open wide. And he went past the lips, the teeth, the tongue, right to the back of the oral pharynx and took a swab for strep throat. And I was like, wait. You just, in a matter of 2 seconds, just jumped past everything that we all took about 4 years of our lives to learn about. And I think that this is really important. Nobody should know the anatomy more than we do in our area. So we have to know the bony anatomy of the maxilla, all the landmarks. We have to know the arterial supply, you know, as it comes off the external carotid. We'll talk about that in a few minutes also. The venous drainage as it goes down the external carotid. We also need to know the nerve supply. So we know that it comes off cranial nerve number 5, and of course the second division for that. In addition to knowing the maxillar anatomy, we need to know the mandibular anatomy, all the bony points and prominences that we need to know. We also need to know the arterial supply too, as it comes off the external carotid, and also the first division of the maxillary artery, as well as the nerve supply from the 5th nerve, the actually V3 division. Okay, so what we need to do now is we need to think about the patient's anatomy before we do anything. As we're planning our implant cases, as we're designing our implant flap design, as we're determining the type and the amount of implants that we're going to place and the prosthetics, what we need to do in our mind's eye is to envision the patient's anatomy as we make our incision, as we start to reflect our flap, to think about what anatomical structures we're going to have to deal with as we go, whether they're bony or nervous or soft tissue or blood vessels too. Okay, and this will allow us through a great degree of success for a surgical patient. Secondly, this whole process is predicated on atraumatic extraction techniques. And what we need to do is we need to think in terms of leaving as much bone as possible to work with. And what I like to say, and hopefully I coined this expression, is that it's easier to preserve rather than to reconstruct. And this will also allow us to have a great success for a surgical patient. Yes, as we used to joke about in oral surgery program, is that yes, you take off enough bone and you will get the tooth eventually will come out. But we don't want to think in terms of those ways. All right, so now how do I approach this? What I want to do is I want you to do the same thing. I want you to think about the patient's anatomy before we go into there, before we start treatment planning, we start planning our case. And I want you to think about how you're going to remove this tooth. And this is what I do. I want to think in terms of how I'm going to elevate it, how I'm going to section the tooth, how I'm going to deliver the tooth with a forceps, and how we're going to try to preserve the patient's bone. Also, periosteum. Nowadays, we want to try to limit the amount of periosteum that's actually reflecting. Let's try to keep the tissue around our bony anatomy if we can, because the less periosteum we reflect, less chance of bony resorption that we have to deal with later on. Okay, so my technique. So I'm always asked as oral maxillofacial surgeon, what technique do you have in taking these teeth out? Well, this is the process that I go through. So the first thing I'm going to recommend we do is that we create what we call a mini flap. I like to use a number 15 blade. And what I like to do is I like to go to the tooth in front of the tooth that I'm going to be taking out and just gradually lift up that papilla of the tooth in front. Then I'll go intrasulcularly around the tooth that I'm taking out with my number 15 blade, and I'll go distally and lift up the papilla of the distal tooth distal that I'm taking out. And then I'll do the same on the lingual. And what I'll do then is I'll just reflect the flap. I'll lift up a little bit on the buccal, about 2 millimeters or so, and a little bit on the lingual, about the same 2 millimeters. And we'll talk about that in a few minutes, why I do that. Number two, what we need to do now is if we're going to take this tooth out, we need to develop a space into which we can lift up or deliver this tooth into. That's why these periodontally teeth that we take out that have periradicular radiolucencies are so easy to take out, because nature has created that space that we want to deliver the tooth into. Okay, well, how do we go about widening the PDL? Well, we can use a burr to widen the PDL. The burr that I like to recommend that we use in my practice is it's a flame-shaped diamond. What we like to do is I like to go around that tooth and just kind of go into the periodontal ligament space and just widen out that periodontal ligament space. Of course, when you get on the buccal, you get on the lingual, be careful not to go too far inferiorly, but on your buccal and lingual, be careful of your anatomical structures. Obviously, you don't want to go too far to the lingual, and once again, as we said, don't want to go too far inferiorly where you can potentially enter into the nerve canal or the sinus up above. Okay, next, what else can we do to widen out the PDL? Well, we can use a periotome. And the purpose of a periotome is you actually take this instrument, which looks like a straight elevator, and you like to place it into the periodontal ligament. You like to just push and advance, and the whole idea is you want to take this firm elevator and place it inside the periodontal ligament space. And we know from physics is that two things can't occupy the same space at the same time. So if we're actually gently taking this elevator and wedging it into that periodontal ligament space, we have to create movement of that tooth and create a widened PDL in which to deliver this tooth. Okay, next, we can use a piezo to help widen our periodontal ligament space too. And in our practice, we've gone through about 3 different types of piezos. There's a whole bunch on the market. This is the particular one that I like to use. And what I like about this particular piezo is that it actually is really, really kind to the tissues, less chance of doing any soft tissue damage. It cuts the bones pretty efficiently, and as well as less damage to the adjacent bone. What I like to do when I'm using these extraction tips, I like to just enter into the periodontal ligament space at about a 45-degree angle. And it's just, as you can see, it's a gentle up and down, up and down, up and down. And they have some really nice extraction tips with this particular setup. As we go up and down, up and down, up and down into the periodontal ligament space, we're actually widening out the periodontal ligament space, once again, creating a space that we can deliver or extract these teeth into. Pretty atraumatic. Okay, what we're going to do next. Now, we're going to elevate the tooth with the appropriate elevators. If the tooth doesn't seem to be ready to be taken out yet, we're thinking in terms of sectioning the tooth. Of course, we all know that maxillary molars, we tend to want to section along a peace sign. If you look at the tooth occlusally, you're going to enter in from the buccal, through the buccal furcation, right through the top of the tooth to the central groove, and then we bear off mesial and distal like a peace sign. We like to separate the tooth up into its individual root components and then deliver the tooth and take the tooth out. Mandibular molars, we like to just generate, because it is a tooth-rooted tooth, we like to take our burr and go straight through the furcation from the buccal all the way through to the lingual, create the 2 separate teeth, and take them out individually. And then once the tooth comes out, we like to remove all the granulation tissue. I like to use our curette. Remember now, be careful of your anatomy. You want to scrape out all that granulation fibrous tissue, the remnants of a periodontal ligament, but be really careful about a thin buccal plate, a thin lingual plate, or be careful if you're right on top of the nerve or up by the sinus. Just really aggressively curette that area out. You want to get some good bleeding of bone, and what we want to do is we want to establish good bleeding of bone, because that's important for our bone grafting. We want to practice what we call a regional axillary phenomenon. And what we're going to do here is we're going to actually just scrape up that bone, get those bone cells going, get some good blood supply, get some platelets going. It's going to help our bone graft. Obviously, if you don't have any bleeding points, what we're going to do is take a small round burr and enter into the lamina dura and create some bleeding points. Of course, be careful of the adjacent teeth that are in that adjacent to the socket. Next, once the tooth is out and we clean out the granulation tissue, we're going to think in terms of socket preservation. Now, when we take a tooth out, what typically happens is that the area is going to heal from the bottom up slowly like a V, and that's the bone, and the soft tissue coming in from the top. If we do some socket preservation or socket site grafting, what we want to do is just place some bone grafting materials inside that socket, and we actually want to place a membrane on the top of that socket. This way we allow the bone to grow from the bottom up and prevent the soft tissue from coming in from the top down. Now, do we have to bone graft every single socket? No. But literature shows us is that if we don't bone graft the socket, typically over the first year we can lose about 40% of the socket width, and then an additional 25% in the second year. But literature also shows us is that we don't need to bone graft these sockets as long as there's 2 millimeters of buccal bone. All right, so if we take a tooth out, we have 2 millimeters of buccal plate there, we don't need to graft that socket. If we don't, we need to graft that socket. Okay, what literature also tells us is that we also need to have about 2 millimeters of attached gingiva around our implants. And that's really important to help prevent maybe some mucositis or some peri-implantitis along the way. Of course, your type of implant you choose also has a big factor into that. We'll talk about that in a few minutes as well. All right. Now, what I'm going to do is I'm going to show you my very predictable bone grafting technique where we kind of recreate a lot of bone that's missing or preserve the bone that's there, in addition to regenerate a whole band of a good keratinized attached tissue that we need for our implants. Okay, but just to be complete, there's 4 different types of bone grafts. There's an autograft, of course, that's the graft that comes from the patient himself or herself, and that's like they call the gold standard. Alloplastic materials are materials that are man-made. We don't usually like to use these around inside our sockets that we plan to place implants into. Once again, we just don't want to have implants placed against a synthetic form of bone grafting material. We want implant to bone contact. Allografts are bone grafts that are taken within the same species from one individual, so to speak, to the next. And xenograft is from one species to another species. Okay, and all bone grafts heal in one of these 3 different ways. We have osteoconductive, which allows bone growth, growing right through our bone grafted material that we place there. Osteoinductive, our bone graft material itself actually causes new bone formation. It actually signals in some osteoprogenitor cells to come into that area, replace our bone graft and form our bone graft. And of course, osteogenesis, when we take live bone cells and place them into another area in the patient's mouth, into another area, that we get good bone growth from live cells. Okay, now, once again, once we take the tooth out, we place some bone grafted material inside that socket, and then the question becomes, what type of membrane do we use? Do we use a resorbable membrane or a non-resorbable membrane? All right, so most of the resorbable membranes that we use nowadays in clinic situations do require primary closure on top of those particular membranes. Most non-resorbables do not. Okay, so the technique that we use in our practice is that we use typically a PTFE non-resorbable membrane. And what we like about this non-resorbable membrane is that you don't need to get primary closure. It's going to help develop some keratinized tissue. So think about that last mandibular first molar that you took out, maybe you had some periodontal disease around that area. Typically, we tend to have in that area maybe about a 0.5 millimeter, maybe 1 millimeter of attached tissue. Let's say we take the tooth out, put some socket grafting, put some bone material inside that socket, and we're going to place a resorbable membrane. When we place the resorbable membrane, most of the time, as we said, we need primary closure. So picture taking that buccal tissue and pulling it all the way over to the lingual to get some primary closure. What did we just do with that 0.5 millimeter, that millimeter of attached tissue? We just moved it from the buccal all the way over to the side, to the lingual side. We kind of lost that whole band of attached tissue. But in this technique, what we like to do is I like to take an oval-shaped PTFE membrane. I like to contour it like an hourglass prep, and I like to take a little bit of tabs off the top and bottom. And these tabs allow you to tuck underneath the tissue. All right, so here we have, remember a couple of slides ago after we take the tooth out, I was telling you how we take the tooth out. What we like to do is create a buccal flap and a lingual flap. I like to lift up the tissue about 2 millimeters on the buccal, 2 millimeters on the lingual. The purpose of that is I could take that contoured PTFE membrane that I just took, that non-resorbable membrane, I could tuck a little bit underneath the lingual. Then I could pack my bone graft after I kind of scrape across and remove all that fibrous tissue, that granulations tissue, any remnants of the PDL, get some good bleeding, place my bone graft in my socket. I like to use a 50-50 presentation, a cortical cancellous allograft, and you can see the size there, 200 to 1,000 millimeter particle size. I find that the cortical component kind of maintains the space, and the cancellous component allows the blood vessels to grow through that bone graft and be replaced and bring in some good bone healing cells. And then what I'll do then is I'll take that other tab and just tuck it underneath the buccal. Okay, so this is when I use an allograft. What we also like to use in our practice is an LPRF technique for socket grafting, where we create this bone block, or sticky bone, as they say. And what happens in our practice is the patient comes in. What we'll do is we'll start an IV. We draw off, in this particular case, this is the LPRF technique. What we do is we draw off a white top tube and a couple of red top tubes. We place it into the centrifuge. And that's the centrifuge that we tend to like a lot in our practice. We set it for about 2,700 RPMs, and it spins for about 3 minutes. What we do is we take out the white top tube, we place that on the side, close down the centrifuge, and we spin the remaining tubes inside the centrifuge. After we rebalance with a fake tube there, just filled up with some normal saline, for an additional 9 more minutes. If they're taking blood thinners, we add an additional 6 on top of that. After the centrifuge spin is over, what we do is we take that white top tube and we pull out that liquid fibrinogen, as we call it. We fill it up into a 3 cc syringe. Typically, we get about a cc or so. We place it on its side. Out of the red top tubes, what we're going to do is we're going to take out that big clot, as you see there, that yellowish clot. And you saw when we take it out of the test tube, it tends to come out with that red blood cells. We like to gently cleave off that red blood cells. The interface between the clot and that red blood cells that we just took off, you see that redness to it. What happens there is that's a great place where there's a lot of platelets and growth factors. We'll place it into our expression tray. We put on the weighted press on top of those clots. We put on the top of the container. We leave it for about 3 to 4 or 5 minutes. We take these flattened membranes and cut them up. What we do then is we add it to about 0.5 grams or 1 cc of allograft bone. We mix up that process, and we take that liquid fibrinogen, kind of just irrigate it out, squirt it on top of that process, mix that whole process up for about another 10-15 seconds, and we get what we call that block bone or sticky bone. And what we do here is we'll take that and place that into the socket as well. We like doing this process here because now we get some good platelets, some good growth factors. What I like about the LPRF process is it gives us a good time release of growth factors coming out into that area for about, they're released over about a 7 or 10 day period. You can see here what we do is we take the other end of that non-resorbable membrane and tuck it underneath that other buccal cuff that we created. What we'll do here is we'll suture that. And then what we do here is we leave the sutures in for about 2 weeks. And then in 2 additional weeks after that, we leave the membrane in. At the end of the month, we take out the membrane, and this is what the socket looks like when we take out that membrane. So it looks a little red, it looks a little inflamed, but it's not. You might have little pieces of bone particles there, you just clean them up, and then you let it heal up, and in about 3 months, you get a good thick band of attached tissue. This is actually 2 different patients, but you can get the idea that you get this good thick band of attached tissue. So now what we've done in this technique, we've created a good band of bone and a good band of soft tissue in which to place our implants and restore our cases too. Okay. All right, so let's move on now. Maxillary sinus graft surgery. Okay, just like we talked about before, it's very, very important for us to know our anatomy. And when we're talking about the maxillary sinus, typically the sinus takes on almost like a triangular presentation, with the base being against the lateral wall of the nose. Our apex of this triangle is towards the zygomatic process of the maxilla. Our roof of the maxillary sinus of this triangle that we're talking about is the floor of the orbit, and the floor of this triangle is the alveolar process down below. And you can see typically the size or volume of the sinuses that we can graft with. Okay, so the arterial supply, of course, it comes off the external carotid, and that goes off actually the maxillary artery of the external carotid, and even more specifically, the third branch, the third division. Okay, so what happens in the sinus, we actually have an anastomosis between the posterior superior alveolar artery, the infraorbital artery, and the posterior lateral nasal artery. This whole complex will supply the maxillary sinus. And when we do our sinus graft, we count on this whole complex just giving some good blood supply to our sinus graft. And of course, it's very, very important to notice where that posterior superior alveolar artery is, because we want to make sure we don't enter into it if we do a lateral approach. Okay, so we talked about the arterial supply. We should mention the venous supply. The venous supply kind of mirrors the arterial supply and drains down the external carotid. The nerve supply, as we mentioned previously, we said that this comes off cranial nerve number 5, the second division. We have here the posterior superior alveolar nerve, the middle superior alveolar nerve, as well as the anterior superior alveolar nerve and the greater palatine nerve. Okay, so let's jump in. Maxillary sinus graft surgery. There are several contraindications. These are absolute contraindications. So of course, if somebody presents the day of surgery with an active sinus infection, you want to just put that particular procedure off until they clear it up. Uncontrolled late-stage diabetes, cystic fibrosis, these are all absolute contraindications for this procedure. Relative contraindications, sometimes we'll have a patient comes in with a periapical abscess of a maxillary tooth. We recommend to treat that tooth, whether it's endodontically or maybe extraction. We always recommend too is that what you want to do is that you want to treat these situations first. And once again, take a relative contraindication and then turn it into an indication. So if you need to do an extraction, we recommend taking the tooth out, let it heal for a couple of weeks, and then doing your sinus graft. Typically, you have less chance of a postoperative infection this way. If you have a mucus retention cyst, we can remove it ahead of time. You can drain it ahead of time. You can send it to ear, nose, and throat, or we can actually remove it once we enter into the sinus and then go ahead and repair the sinus and do our graft. If somebody presents, as we'll check out on a cone beam, we'll talk about that in a few minutes, with a blocked osteometal complex, that's something that you could send to an ear, nose, and throat. They could do what's called a FEST procedure and open up that area of potential drainage. Okay, another contraindication we can talk about is smoking. So smokers typically have about a 7% greater failure rate than non-smokers. And empirically in the literature, you can see that they recommend maybe stopping smoking for about 2 weeks before and then following up with stopping for about 4 to 6 weeks after surgery. This is just purely empiric. Okay, now, how do we treat the posterior maxilla? How do we decide what type of sinus graft do we do? Well, what we do is it's based upon the amount of residual bone that we have to deal with. So there was a sinus consensus in 1996. This mirrors the MISH protocol for classifications of the posterior sinus. And what it goes is it goes 1, 2, 3, and 4. So in SA1, typically these sinuses, we're talking about a good amount of width of bone for all these particular classifications here for this particular webinar, but we're talking about now bone height, residual bone height. So an SA1 classification has greater than 10 millimeters of bone height available to place implants. Our SA2 has about 7 to 9 millimeters of vertical height bone remaining in the sinus. SA3 has about 4 to 5 or 6 millimeters of bone remaining, and SA4, there's only about 1 to 3 millimeters of bone left in the sinus. So once again, the residual amount of bone determines what type of procedure we're going to do to graft these sinuses. Okay, so our surgical workup, of course, will include a cone beam scan. Now, why do we do a cone beam scan? What we want to do is we want to evaluate the sinus anatomy. We want to see typically how much vertical and horizontal bone width we have, and of course that will determine the type of bone graft that we're going to do. We want to see if there's any septum in our way. Are there any cysts along the way? Is the membrane thickened? And it's so much, it's not an oxymoron, but it's almost funny that a thickened membrane is kind of good because those membranes tend to lift up pretty quickly. So somebody who might be a smoker, somebody who lives maybe in an inner city where they have a lot of contaminants, environmental causes, you might get a thickened membrane, and those are easier sinuses to lift up. We want to see if there's any sinus infection, any sinus pathology. We want to also check out, very, very important, you can see this on this coronal view, a patent osteometal complex. Don't do the surgery if you don't see a patent osteometal complex. Sometimes some medications or a visit to the ENT can help clear that up. And once again, we want to see where the posterior superior alveolar artery is. We want to make sure it's not in the line where we're going to go. Okay, and once again, depending upon the residual bone height, that determines what procedure we're going to do for grafting our sinuses. Okay, so ASA1. In the ASA1 case, what we have here is we have greater than 10 millimeters of bone. These typical patients just follow a classic implant protocol. We place the implants, no need to do any type of vertical augmentation. What we do is we restore these implants in typically about 3 months. And of course, sometimes we'll go longer if there's a softer bone up there. Okay, so that's SA classification 1. Okay, next. SA classification 2. Here, the amount of residual bone that we have is about 7 to 9 millimeters. Okay, now the magic number, we're always asked this question, hey, what amount of bone do we need to be able to place the implant in addition to doing the sinus graft at the same time? So that magic number is 5. So if you have 5 millimeters of vertical bone height, you can actually place the implant and do the bone graft, the sinus graft at the same time. And that holds true through a crestal approach or a lateral window approach. Okay, so of course, now in this particular case, we have about 7 to 9 millimeters in SA2 of vertical height remaining. Here, we're probably going to lift our sinus maybe 1 to 2 to 3 millimeters just to get enough bone vertical height above the size of the implant that we want to place. Okay, so crestal sinus lift. Here, as we said, it's indicated when you have about 7 to 9 millimeters of vertical bone. What we're going to do here is we're going to gently, whatever process we do, gently infracture the antral floor, lift up the membrane, add some more bone, and if we have 5 millimeters or more, which we do in this particular classification, we can place the implant at the same time if we would like. What we do then is, in this particular case, if we do place the implant and do a sinus graft at the same time, instead of restoring these cases in 3 months, I typically wait about 5 months to do that. Okay, well, what options do we have now if we want to do a crestal or a vertical lift? Okay, well, these are the options that we have. These are the 3 techniques that we tend to recommend. The first one is the osteotome technique. And what we're going to do here, this is a technique that some of us older oral surgeons will tend to do more, used to do more so than not. And what we do here is we drill to within about 1 millimeter or 2 from the bottom of the sinus floor. And then we take these osteotomes, which typically are tapered instruments, we place them into that osteotomy that we just created, and through a gentle tapping approach, we're going to infracture that 1 millimeter or 2 of bone that's left underneath our sinus floor. And as we're doing that, we're going to gently infracture that sinus floor and lift up the sinus membrane. This allows us to expand the bone, it allows us to condense the bone as well as lift up the sinus floor. What we'll do then is we typically place some particulate bone graft, insert that osteotome, once again, tap, lifting up that bone material as it lifts up the bottom of the floor of the sinus, as it lifts up our sinus membrane, we are increasing and creating more vertical height to go around our implants. Okay, and typically this is what a case looks like. Here's our cone beam. We have about 7 millimeters residual bone. We'll go in there and do an osteotome technique. What's nice, it laterally condenses, also widens out our osteotomy, and there's our implant placed with our bone graft. Okay, so a complication that can occur, and thankfully it's not often at all, is that when you use these osteotomes, this tapping technique, you can get what's called a benign paroxysmal positional vertigo, BPPV. And a lot of times this can happen is by dislodging the otoliths of the inner ear. It usually resolves by itself, which is kind of good. Sometimes some sedatives are necessary, but if it doesn't go away, we recommend a trip maybe to an ear, nose, and throat, or even chiropractors now are treating these through positional exercises, and they're typically called the Epley maneuvers. Okay, next, if we want to do a crestal or internal sinus lift approach, here we have an osteodensification technique. And here what we're doing now is we're actually using a non-cutting burr. We're running it in reverse under a lot of irrigation. And as we're doing that through an up and down approach, we're actually condensing our bone laterally and inferiorly. And this autografting technique that we're doing increases our bone density and also aids in our initial stability when we place our implants. And the funny thing is this is coming pretty much vogue in our literature and the courses we're taking for the last couple of years, but it's actually been around a long time prior to that in the orthopedics. And you'll see it a lot in the hip and knee replacement literature too. Okay, so once again, what we're going to do is we make our starter drill. We're running these drills in reverse under a lot of irrigation, and it's a gentle push, pumping up and down motion. As we're doing that, we're creating and putting that pressure. We're laterally condensing, apically condensing, and widening out our ridge. And then when ready, we place our implant. Okay, next. Lastly, when we recommend crestal lifts, the last technique we recommend is a crestal sinus drill kit approach. And what this has done is that this is based upon a series of drills that don't cut the sinus membrane, and it's a series of protective collars that help you to guide your osteotomies. Okay, so what we do here is we start off, we kind of measure from our cone beam scan. Maybe we measure, this say 7 millimeters of bone. What we like to do is we put a protective collar underneath our starter drill. We like to go into and create an osteotomy to about maybe 1 millimeter or so or less to the apical or the bottom part of the sinus floor. Then what we'll do then is that we take a PA just to confirm our position. Then what we'll do is place a smaller collar there. So in other words, it will allow us to drill, instead of 7 millimeters, it allows us to drill 8 millimeters. And what we'll do is we'll drill down to that osteotomy again. We'll keep drilling down until we get to the required depth. In other words, we'll drill here with a collar that allows us to drill 8 millimeters. If we don't get far enough down, we'll switch that 8 millimeter collar now to a smaller collar, which allows me to use 9 millimeters of our drill length. And we'll keep drilling down. And once again, these tips don't cut the sinus floor until you drill, until you kind of feel that little give. And once that sinus floor kind of gives, then that collar that we placed on this burr is the collar that we're going to continue on and use now for the rest of the case. So now what we're going to do is use that same size collar. I guess in this particular case, it allows us to drill, say, about 8 or 9 millimeters. And what we're going to do now is widen out our osteotomy to the size that's necessary to place our implant. Once we do that, we're going to pack our bone. I like to use Preparation here is typically a xenograft preparation because I like the fact that it's going to be around there for a while, and it's also radio opaque, and I get to see that on my PA afterwards. We're going to condense our bone after we gently pack it in there. Once again, you can see here the protective collar fits over that condenser as well. Here we are adding the material, lifting up the bottom of the sinus, lifting up the sinus membrane, and creating more vertical height for us to work with. Okay, then what we're going to do is place our implant. The implant of choice here I like to use a tapered implant. I like my surface that's textured with laser, and I find that this tapered implant really gives me great initial stability when I do these crestal lifts, and I place the implant at the same time as I do this crestal lift. I like the surface to be treated with a laser because I feel like you get good soft tissue attachment, less chance for mucositis and periimplantitis. Okay, so you can see here is our clinical picture here. We have an implant placed there. We have a nice little dome-shaped bone placed there, and that's very, very important when we do these cases that you see that. It basically shows us that that whole bone graft is pretty well contained underneath the sinus membrane without a perforation. Okay, and once again, we let these heal, not the typical 3 months before we tend to expose and load. Here, we're probably going to let it heal for about 5 months. Okay, next, let's talk about now, we talked about SA1 and SA2. SA3, we have here about 4 to 6 millimeters of residual bone height. Okay, so once again, we have that magic number of 5. These cases we can restore by placing the implant if we want to at the same time we do the crestal lift or not. But we have 2 options here in an SA3. If we have 4 to 6 millimeters of residual height, we can treat it with a crestal approach, which we just talked about, or we could do a lateral window approach. When we're talking in terms now of SA4, here in these particular cases, we only have 1 to 3 millimeters of vertical height remaining, and here a lateral approach is the only approach that we can use predictably. Okay, so in SA3, we can do crestal or lateral, SA4, only lateral. Okay, so we talked about crestal, so let's talk a little bit more about lateral. Okay, so when we're designing our flap now for a lateral lift, what I like to do is 1 to 2 millimeters, I like to go anterior to our expected site that we're going to make our lateral window osteotomy. What I like to do too is I like to include the papilla in my flap, and I find is that it just tends to suture up and close nicely that way. We're going to make our incision. We go vertical release, obliquely, include the papilla, go intrasulcularly, and then go right across our crest, and sometimes we place a distal release there too. Okay, now, when we outline our window, we're going to look at our cone beam scan. We're going to see the area that we need to place our, do our lateral lift within, and we're going to check out the bony anatomy that we talked about before. Now, when we outline our window, sometimes we'll use a little burr to outline our window. Sometimes we use a sterile graphite pencil. But whenever we're going to do a surgical marker, we're going to outline our window before we go ahead and do our osteotomy. Now, where do we make our window? Well, inferiorly, what I want to do is I want to stay 2 millimeters above that lip of vertical bone that I have remaining. And then what I want to do mesially, I want to do 2 millimeters distal, so to speak, in from that anterior wall. And distally, you can see here it demarcates 15 millimeters long. That just depends on how many implants we're going to be placing there. And of course, the vertical height. We want to kind of make our bone graft and do our vertical sinus lift. So we're adding enough bone so we can accommodate the small size implant that we want to place. And typically we like to do, or the workhorse in our practice tends to be about 10, 10.5, 11 millimeter implant. Okay, now this access window that we're creating, when we do this lateral osteotomy, this access window, some surgeons, what they'll do is they'll actually just obliterate that whole window, and some surgeons will leave the window, and when they elevate the membrane, they use that window, that bony window, as the sealing of their new sinus graft. Okay. Now, there's several ways to access this window, but before we get into that, let's just review the technique first. So what we said is we're going to do our cone beam scan. We're going to kind of draw out on the patient's maxilla where we're going to access and make this lateral bony window. Once we lift and we start getting this access, this bony window, we're going to start to gently lift the membrane. I like to start mesial a little bit, then I go inferiorly, and then what we're going to do is we're just going to keep pushing that membrane up a little bit. So we go now across the bottom part of the alveolus. We're going to continue that elevation of the membrane up across the medial aspect of the maxilla. Okay, now that part is so important. That medial wall of the sinus is really important because that's where we tend to see a lot of graft failures, where docs will tend to be a little timid. They won't lift up that medial wall, and that's so important to get a good bone take. Because remember now, we need some good bone in there to give us some good blood supply for our sinus grafts. Okay, just don't push too hard because behind that sometimes tends to be the internal max. Once that's lifted up, we'll place a couple PRF membranes on top of that, and then what we'll do is pack our bone, pack that bone to a good consistency inside the sinus. And then what we'll do is, if it's a large enough window, I'll place a resorbable collagen membrane and some PRF on top of that. If it's a smaller window, sometimes just some PRF. Okay, so once again, there are several ways to access this window. Okay, we could do a round burr or piezo. Okay, so when we first started out in practice, what we used to do is we used to take a carbide round burr. And what we used to have us doing is we used to create, instead of a nice oval, smooth shaped window that we in fracture, we designed all these lateral windows in the form of a trapezoid, the trapezoid shape. So what we do is superior cut of the trapezoid, and that's the part that's closest to the crest of the maxilla, the crest where the teeth were. We kind of just take the burr and we cut a little trough across that, just a longitude, a horizontal trough right across there, closest to our occlusal surface. And then we just try to gently take it so we almost see membrane. Then we would do is 2 additional cuts. We would do one mesial and one distal, and these will be oblique cuts, and these will be our lateral walls of our trapezoid, so to speak. And then our superior cut, what we did is they wanted us to infracture that cut. So instead of taking the burr and cutting across like we just did in the other 3 cuts, what they'd have us do is take a burr and kind of make a indentation, a bone pop, a bone pop, a bone pop, a bone pop, as we work from mesial to distal. And every time that we would pop through, we would perforate. And it didn't work out too well. So then we switched from a carbide round burr, we went to a diamond round burr, less of a chance to perforate our membrane. And nowadays what we use is we use the piezo. And love the piezo for a couple different reasons here, but typically my technique is I'll make a flap as we just described. I'll reflect my buccal flap. I'll take a bone scraper, and there's 2 reasons I use a bone scraper here. What we're going to do now is take this bone scraper and actually scrape it across the lateral maxillary wall. What are we doing here? We're actually scraping off and thinning down the maxillary buccal wall. So the 2 reasons. Number 1, I'm getting some good autogenous cells. Number 1, I'm going to mix that into my graft. And number 2, I'm thinning out my buccal amount of bone. So when I do go with my piezo, I'm just cutting for a small amount of time. Then what I'll do is I'll use my piezo to create that lateral wall. And typically nowadays we like to make a nice oval approach, less of a chance of cutting our bone, our membrane, because of the piezo, which works out really, really nicely. Once we lift up our membrane, we just described that, I'm going to place 2 PRF membranes over our sinus membrane. Even if we don't have any perforations, because sometimes there could be some micro perforations, I like to place 2 PRF membranes. Then I'll pack my bone mixture. What I like to do in my sinus graft, I like to do a mixture of a third, a third, a third. So I'll use a third of the patient's own bone. So that comes from the scrapings that I did, and as well as the PRF that we talked about how we mix that up in our practice. The second third is going to be my cortical cancellous mix. And of course, once again, the cortex part will keep the area, help it keep open. Cancellous allows some good blood supply to grow through. And the final third is going to be a xenograft. I like to use the xenograft because it really holds that area open a lot as we're generating some new bones to form in there. Okay, when I typically pack my bone, I like to pack the medial wall first. I'll go posterior medial, then I'll pack way up against my medial wall, and I'll just pack myself anteriorly and buccally. Okay, anterior and buccally you usually don't have to worry about. It's that medial wall you want to get some good bone up in there too. I'll complete my sinus fill, and once again, a collagen membrane if it's a large access with some PRF on top of that. If it's a small one, just some PRF. Okay, so here you can see, this is the piezo in action here. Piezo has some nice little small tips there. It really gets us to create a nice, gentle osteotomy. And what's nice about us using the piezo, I can control the size of the window. If I want to make a small window or I want to make a larger window, I can control that just by gently going across there. Less of a chance of perforating through and popping into our sinus membrane. Typically, the approach that I use when I want to lift up the membrane, I'll go mesial first. And you can see now with this sinus instrument, I'm only touching the inside part of that bone with the tip of the sinus instrument. The back end, the rounded end of that sinus instrument is actually pushing against my osteotomy site, that window, that bony window, and as well as the membrane, I'm just gently lifting it up. And then once I do mesial, then I'm going to go inferiorly. I'll go inferior down across the alveolus, way across the alveolus, and then up against our medial part. Okay, once I get that reflected, I'll go ahead and place 2 PRF membranes. I might take one and fold it upon itself, depending upon the size of the osteotomy, or place 2 membranes there to protect, and I'm going to bone graft against that membrane. Okay, and we talked about our our bone graft that we're going to use. I like to mix up the third, a third, a third. We're going to pack it into the sinus. Once everything is kind of condensed and packed in pretty nicely, here we see we're placing a PRF membrane. I'm going to make sure that that's tucked in well too. The PRF membrane serves two purposes. One, it prevents the bone material that I just packed into the sinus from coming out. And it also, as we place it over the osteotomy, just gives us good soft tissue healing. I mean, you really have tremendous healing with these PRF membranes. And you can see you want to make sure it's just a tension-free closure that takes place. Okay, so next, let's talk about resorb ridges. Okay, we'll finish up with resorb ridges and then we'll do some questions. Okay, so typically a patient might come into your practice here. This is a patient maybe who had just been to a dentist a long time ago, had some teeth taken out. Maybe they have a resorbed posterior edentulous area, or maybe they have a partial edentulous area. Maybe you took some teeth out. Maybe you took some teeth out and did a sinus graft, and maybe it didn't heal up as well as we expected. But this is a clinical situation that we can see often in our practices. Okay, so how do we restore this? And what are our options? Well, we have a couple different options. And what I want you to do is I want you to think about this now. These are our kind of options. We can't take a poll on the webinar today, but what you can do is just kind of think about now. You saw the defect we have. We have some good vertical height, and we don't have a lot of horizontal width of bone there. So three options that we can graft here in our posterior maxilla and mandible will be, we could use a GBR approach, we could use a ridge split or ridge expansion approach, or we could use a block graft. And of course, if we're talking in terms of block grafts, we can do autogenous, or we can do allogeneic bone grafting. Okay, so what I want you to do is I want you just to think about now, in this particular clinical situation, what would you do? Would you do a GBR approach? Would you do a ridge split or ridge expansion approach? Or would you do a block graft or autogenous, whether it's autogenous or allogeneic graft? Okay, so take a couple of seconds. Okay, you ready to vote? Okay, let's vote and let's decide and let's see what the answer is. Okay. Now, how do we determine which is the best way to restore this particular patient? Well, it's based upon where the tooth needs to be. Okay, so what we need to do is we need to go back to our workup. So we need to do an impression, we need to do a wax up, we need to make a radiographic guide, and then we need to have the patient scanned in a cone beam wearing that radiographic guide. And then what we can do is we can take that radiographic guide, superimpose it on top of our cone beam scan. We're going to see the two together on our cone beam scan, and we can see exactly where the tooth needs to be and where the bone is. And we can determine which process would be better for us. Okay, so once again, prosthetics is going to dictate what type of procedures we're going to need to do surgically. So you can see on the left side here, the prosthetics tooth is kind of almost at the top of the ridge. We have some good height, but we have deficient width of bone here. A ridge split or a ridge expansion procedure would be great here, because what we'll do then is just expand out the bone a little bit. And what we'll do is be able to place our implant and restore it exactly place that tooth where it needs to be. Place the implant where it needs to be so the tooth can be restored that way. Now, versus the right side, on the right side, what we can see is that here, prosthetically, that tooth needs to be in this particular situation for the patient. This is where the patient's teeth line up. So here, you can see that a ridge split procedure really wouldn't be that good, because we have split the ridge. We still wouldn't create enough bone. We still wouldn't be able to move that buccal plate all the way out far enough where we can get enough bone to place our implant. In this particular case, a GBR or a block graft would be the graft of choice. All right, so that's how we determine what graft to do. It's not, oh, I just bought this new machine. Hey, let me just do this ridge split. There's some scientific basis to it. Okay, what do we have as far as options now for ridge expansion? Okay, there are a couple of different techniques that are available to us. And it started back with Tatum. And what Tatum does when he's talking about ridge split, ridge expansion, he likes a partial thickness flap. In this particular case, he's going to make an incision across the alveolus. He's going to do a little supraperiosteal dissection, a little bit on the buccal, a little bit on the lingual. He's going to maintain his periosteum on top of his bone. That's how the bone is going to get his blood supply. And he's going to gently tap and separate that bone out a little bit to create some space for the implant. Next technique is an osteotome technique. So some are osteotomes. We talked about this before. Here you can do a split thickness or a full thickness flap. What we're going to do here is we're going to open up that area. We're going to drill, and then gently through the gentle tapping, we're going to laterally condense our bone and as well as increase our bone thickness. Then we will place our implants. Okay, what else do we have available for us? Well, we do have ridge expanders, and these could be the chisels, rotary or hand mechanical expanders. The same thing. This particular process, we make our incision. What we do is we kind of open it up and just gently let the chisels or mechanical expanders expand our bone. Osteodensification. Here we're going to do, as we talked about before, if we're thinking in terms of ridge expansion, we're going to laterally and apically condense our bone while expanding our bone too. Okay, and of course, lastly is our piezoelectric, and this offers some ridge splitting and also expanding options too. And what's nice about the piezo, they have several tips. What you can do is you can actually split your maxilla or mandible, we'll say maxilla, split the maxillary ridge, and they have some tips where you can actually go inside your osteotomy, up and down, and kind of create and expand that ridge as well. Or you can just use it in conjunction with other techniques too. Okay, so I like the piezo because I find it's minimal bone loss with less chance of bone necrosis. I find I get a highly precision osteotomy cut, especially on those thin maxillary posterior areas. This really helps me control my osteotomy very, very well. I preserve my soft tissue. We talked about that before, really important. And of course, now using this technique, I find I'm just delivering less trauma to the area, which translates to me less postoperative pain and swelling and more happy patients and more referrals. Okay. Indication for ridge expansion, what we need to do is you need to, of course, if you have a narrow residual alveolar ridge, you're going to do consider a ridge expansion. But most importantly, when we do look at the cone beam, we need to see a marrow component here. Okay, that's really important. And of course, in these beginner courses that we teach everybody is that you need adequate alveolar vertical bone height. Okay, contraindications we find is that, of course, fused cortices. If you see a buccal cortice, not too much marrow, fused almost to the lingual cortice, it's not a great ridge expansion candidate. Okay, and of course, as we said, if you don't have adequate alveolar bone height, then it's probably not a good case to do initial ridge expansion. Okay, couple things. This is important. This is a big learning curve. We're going to save you a couple of sleepless nights. What happens is that if you're going to plan a ridge expansion, think in terms of, okay, I'm going to make an incision, I'm going to make a cut down that alveolus, and I'm going to move that buccal plate out to the buccal, and I'm going to place my implants. Typically, if you don't do this next step I'm going to talk about, this kind of translates into buccally placed implants. They tend to be too far buccal. So what I like to do, and I'm going to show you in the case in the example in a second, what I like to do is I like to plan out where my implants have to go first. I do my initial osteotomies exactly where the implants need to go, and then I do my ridge split procedure. This ensures that I get those implants to stay where they need to be. Okay, so to sum it up, as far as ridge expansion goes, when you're thinking in terms of ridge expansion in the maxilla, think in terms of a partial thickness dissection if you can. This flapless approach will help preserve a lot of blood supply to that small, thin maxillary area. Now, if you need to mobilize the bone a little bit more so laterally than the first one, what we're going to do then is that think in terms of giving yourself a thicker supraperiosteal dissection. Just think in terms of you need to get a blood supply to that thin segment of bone you're expanding. Now, number three, if you need to expand that segment and also graft the buccal, here we're going to use a full thickness dissection. This is what the case I'm going to show you in a second on our case. Okay, so of course, what does our workup entail? We talked about models, wax up radiographic stent, use a cone beam. The cone beam is going to show us with the radiographic stent where the patient's teeth need to be, and that will help determine what type of bone technique we're going to do, bone grafting technique we're going to do. Okay, why is it important to look at the cone beam scan also? It's important because it shows us how much ridge width we have and height we have. It shows us the sinus anatomy. It shows us the volume of medullary bone. Remember we said if you're thinking in terms of ridge split for ridge expansion, you need medullary bone. We can't expand cortex on cortex, okay? It also shows us the patient's residual ridge if we're dealing with any type of undercuts or so. Okay, so in ridges that we already have about 6 or 7 millimeters of horizontal width of bone, the width of bone, in these particular cases, we probably don't need that big expansion. We're probably going to think in terms of expanding maybe 1 to 2 millimeters of bone, okay, of the distance. Because we know in the literature that we knew when we place our implant in the posterior, we need about 1 millimeter of bone circumferential around our implant to give us a good bone take there. So if we have about 6 or 7 millimeters of bone, we really need to lateralize that bone maybe about 1 to 2 millimeters. In these particular cases, the osteotome, osteodensification, rotary or hand mechanical expanders work just really, really well. Now, if you have a residual amount of bone, say about 4 to 5 millimeters of width, and maybe we have to move that out laterally about 3 to 4 millimeters of expansion, we need some good expansion there. This is where I love to use the piezo here to mobilize that bony segment. And what you can also do too is you can also use this in conjunction with other tips too to do sinus lifts as well. And that's what I'm going to show you in this particular case. Okay, lastly, before we get into the case, I always recommend using an implant design with aggressive taper in these cases and a non-expanded collar. I like the tapered design because what it does is that it aids in the expansion. So as I'm starting to expand my ridge, that tapered design will help push the buccal ridge out, helps support that grafted, that freer segment that I'm initially expanding out. The aggressive thread design can also increase my initial implant stability, and I think that's really important in these cases because you don't want that implant spinning around in a bone grafted site. And I like the reduced collar because it avoids excessive pressure on the coronal portion of my lateralized graft site. Okay. So here's our case, and we'll finish up with this case, and then we'll do some questions here, is that this is the case that presented to us. So this particular patient, we're dealing with the maxillary right quadrant, had some teeth taken out several years prior, and what we're planning on doing now, prosthetically, we were planning about 2 implants for a 3-unit bridge, and I believe we were planning on placing another implant on the lower right-hand side. He just had 1 implant placed by a previous doc, I believe. Okay, so our plan here is the patient had previous extractions which had resulted in a horizontal bone defect. And this particular patient, he also had some sinus pneumatization posteriorly. And sinus pneumatization means that the sinus tends to dip down a little bit, so he doesn't have a lot of vertical height posteriorly. Okay, so the patient presented in the anterior area, we have horizontal bone deficit. In the posterior area, we have okay horizontal bone, but we're actually a vertical problem here. So our plan would be here is what we wanted to do is we wanted to use the piezo to perform a horizontal osteotomy after we did our flap. We're going to actually use osteodensification burrs to expand our bone, and we chose to use osteodensification burrs to expand our bone because we needed to do a sinus lift as well, and we're going to use those burrs to do our sinus lift in addition to our expansion. Then we're going to place our implants, and then we're going to do an onlay graft. That was our plan here. Okay, so the cone beam scan, this is our patient clinically, what he presented on, a thin maxillary posterior right side ridge. Tooth number 6 looks kind of thin. Tooth number 4 looks pretty good thickness-wise, but height-wise, it's a little deficient here. This was actually a cone beam scan about 3 months or so, 4 months before the patient decided to do. When he presented to us, it was actually less when we opened it up, and you'll see in a second. And so here what we did, we went ahead, and here's a papilla sparing incision. We decided to keep the papilla here. The general dentist who referred to us was very concerned about the crown he just recently placed, and he didn't want to have any gingival pullback there. So what we do is we make our vertical oblique approach. A papilla sparing incision, so we're going to leave the papilla behind, so to speak. We kind of go a crestal incision, and here we didn't make our distal release. We lift it up buccally, and we lift it up palatally. Okay, now, remember, this is the key. This is the key to the whole procedure. Once again, if you don't do this, there's a chance that you can do your ridge split. You can push your bone out laterally, and you place your implants too far buccal. So we recommend taking a starter burr, precision burr, and we're going to place that initial osteotomy exactly where those teeth need to be. And this, of course, can be done by a splint or so, which we don't show here. You're going to place the initial osteotomy in tooth number 6 position, skip a space for our 3-unit bridge, and go to tooth number 4 position. And we're going to go with that initial precision burr. And once again, these are the spots where the implants have to go. I'll even go so far as to go to my 2-millimeter drill, and I'll go right into tooth number 6, and I'll go to the depth that we need to go. Once again, here we have some good depth. We just don't have good width here in this particular case. And then I'll do the same thing in the posterior side. In the posterior side, we have okay width, but we don't have the height there. Okay, so now I'm kind of assuring that these are the 2 areas where my implants have to be placed. Less of a chance of pushing that whole segment buccal and placing our implants too far buccal. Okay, then I'm going to start off with the piezo. So here, I like this tip when I start off my ridge split, and you really appreciate now. See how thin that area is right in tooth number 6 spot. And you can see that this allows me for a really fine precision cut. There's a lot of irrigation here, so we have less chance of burning any or getting any necrotic bone. And then what we'll do here is in the posterior area, tooth number 4, we can see I'm still cutting across that alveolus. I have okay width here, but I don't have the sinus depth. I don't have the depth that I need here by the sinus. Okay, once we get that initial osteotomy going, we'll use the same tip now, and we'll tend to go a little bit deeper now. Once again, in tooth number 6 spot, I can go until about 10, 11, 12 millimeters. That's not a problem. But as we swing distally into tooth number 4 spot, I don't have the vertical height necessary to place the implant. So I have to be very cognizant of the fact I can't bury that whole piezo tip there. And once again, I'm just going to cut it across there too. Really atraumatic to the area. And then what I'm going to do here is I'm going to actually use those osteodensification burrs. We run this in reverse with a lot of irrigation. And these burrs are going to help expand out that buccal plate of bone. They're going to help expand that buccal segment of bone now too. I could use the piezo tips. Piezo has a lot of nice tips too, where you can go in there and they have a series of sequentially larger taper tips. I could do the same thing, but since I was going to do a sinus lift too, I was going to just use that, so I decided to do with this protocol. And then what I did is I go to the next size non-cutting burr, running in reverse, and up and down motion. And here what I'm doing is actually expanding that buccal plate. So that incision, that osteotomy cut that I went across the alveolus, I'm actually expanding that buccal plate out. And then what I'll do is I'll place my implant. I'm placing the implants under a lot of irrigation. I told you the type of implant I like to use. I like to use the tapered with the reduced collar here. I like the aggressive threads here. And it just gives me a good bone take. It gives me good initial stability. And I'll go ahead and place this implant all the way down. And then for the posterior implant, I'll do the same thing. Sometimes I'll just put an indicator inside that implant, and then we'll place and we'll use those same burrs now, running in reverse with some irrigation. And here what I'm doing is I'm expanding the ridge a little bit, yes, but I'm also infracturing that sinus floor, and I'm going to do my bone graft right through that same area. So I place my bone, and then what I'll do is I'll cut back on the RPMs on those burrs, and I'll run that burr in reverse again. And then I'll actually, what this will do is it takes the bone grafted material and it kind of displaces it. Once again, these burrs will allow me to infracture the floor of the sinus. I lift up the sinus membrane, pack some bone, reduce my RPMs, run it in reverse, and I actually take that bone and just kind of push it into the sinus, push it into the sinus, and create that nice dome effect. Once I get the amount of bone that I need superiorly, I'll go ahead and place my implant, making sure that the implants are in the exact position that they need to be, and they're not pushed too far buccal. You can see the expansion on that first number 6 site. You can see there's like a little break in the bone there because we really had to expand that out far. Remember, that was that thin ridge. And we'll go ahead and place our implants there. And you can see there's our osteotomy cut. We have our infractures of our bone, and you can see the expansion that took place as well. Okay, and once again, next. So implants in good position, great initial stability. What we're going to do next is we're going to do our submucosal space technique, but we need to make sure that this is going to be some tension-free closure. Hamle Wang did a study, and he said that if you want to mobilize flaps, whenever you make an incision, that gives you typically 1 millimeter advancement. So our crestal is 1 millimeter, our distal release, our mesial release is 1 millimeter. And here what we're doing is we're actually scoring across the periosteum. So we're going to go from the front of the incision all the way across the back, and we're just going to score that periosteum. Once we do that, we kind of jump a little bit higher up. We score it again about 1 millimeter up, jump again another millimeter, and we just want to get a good tension-free closure there. Be careful as you get to the superior part because you don't have any facial muscles there to deal with. Okay, and what you do is we take some more PRF preparation. We're going to put our resorbable membrane in there on the palate, pack all our bone against that palatal membrane there, really kind of pack it in. We like the PRF preparation once again because we get some good platelets, some good growth factors coming in and mixed in with our bone graft. And we're just going to pack that really in there on the palatal part. Okay, once that's packed in there pretty well, what we're going to do is we're going to start to pack, and we're going to pack against the buccal part now. Or we like to take that sticky bone, that bone block, and just kind of put in there. I like this preparation because it really keeps my bone grafted material where it needs to be. It doesn't have it flowing all over the place there too. Once I kind of compress it and really pack it in where it needs to be there too, we're just going to tamp it down a drop there too. We're going to fold over that resorbable membrane and make sure that this tucks underneath the periosteum. And as we said, is graft immobility is going to be the key. And then we're going to go ahead and we're going to suture that up. Okay. Once again, before we do that, we'll just do some more submucosal incisions to get some more laxity to our flap. I like to typically close this in a double layer type of approach. And I'll show you the last 1 or 2 slides, and then we'll take a couple questions before we finish up. We're packing here our PRF membrane. Once again here, this gives us just excellent soft tissue healing. Patients definitely have less swelling afterwards, and then we're going to close up with a 2-layer closure. So what I like to do is I like to do a subperiosteal approach here to close it. And this is like a subperiosteal sling suture. We'll enter in on the palate. We'll kind of come across the buccal. We're going to engage low down deep that periosteum of that buccal flap, come across through the palate. Same thing again. Engage on that buccal, kind of come across there. And what we're actually doing is just grabbing the periosteum down low on the buccal, kind of pulling it against our graft, and we're tightening it down. Here we have some resorbable sutures, and we're going to just tighten that up in place. This gives us great graft immobility. Once we do that, we're going to now close superiorly, close our skin incision, and we typically like our skin incision with some PTFE sutures, and we typically remove them in about a month or so too. Okay. All righty. So that's our post-op view, and you can see we got this nice ridge split. We got some good onlay grafting. We get some nice vertical sinus crestal augmentation as well. So this particular case I put in there because it shows just about every concept that we kind of talked about today, which I thought was really, really good. Okay, so we're finishing up right now, and what we're going to do is we're going to open up now for some questions. And I know the webinar is supposed to be about an hour. So what we're going to do now is, as we'll do, I'll answer some questions now. And I saw there's a bunch coming through. And what I'll do now too is, why don't you all take down my Instagram handle? You can see at the bottom of the screen right there. Just write that all down, take that down. Follow me after the webinar. I'll follow you back. And I think that's a great way that we can exchange information back and forth. And that's how learning takes place. It makes it fun for everybody. If you also have a couple questions that I don't answer right now, because I want to be cognizant of the fact that we have an hour webinar, is that just shoot me a DM and we'll talk about that stuff as well. Okay, so let's cover a couple questions now. Okay, let's make sure we do that. All righty. So let me take a look at the question and answers here. And we say over here, okay. So the first question I have is, what forceps do I like and what do you recommend? Okay, so I typically have about 5 forceps that we use in our practice. And I like an upper universal, I like a lower universal, and that will take out basically any tooth in the mouth. I also like a straight upper forcep, and I use that on the maxillary second premolar to second premolar. I use a straight upper forcep. From second premolar to second premolar, like an ash forceps, and then any mandibular tooth that has a furcation involved. Okay, question. Kelly asks, after the ridge split and large membrane placement over the particular bone, no need for tacks to hold down the membrane? Great question, Kelly. Yes, you can use tacks if you'd like. You can use resorbable tacks, non-resorbable tacks. In this particular case, I just wanted to show the subperiosteal suture, and then you can see how the way we kind of just grab that and hold that whole membrane down across that bone graft, and that bone graft's not going anywhere. But very important, remember, it's graft immobility. So yes, you can use tacks, and here's just a subperiosteal suture. Thank you all very much for the nice comments that are coming through too. Very, very nice. Thank you. One question is, during our sinus lift, how long do we wait until we place the implant? So I typically wait about 6 or 8 months. It depends upon the size of the sinus defect that we have to graft. Also the age of the patient. Of course, the healing capacity of the patient factors in. Using the PRF, of course, it does tend to be less time involved too. Next. Do you also use the piezo for other autogenous grafts in the mouth? Yes, I do. So if we were doing a block graft, I like to use the piezo for, I like to do an anterior mandibular chin graft. I'll do that. If we're talking in terms of anterior mandibular chin grafts, what we like to do is we like to use the rule of 5s. So if you have the mandible exposed, whether you do a vestibular incision, you do a crestal incision, a sulcal incision, excuse me, and flap it and expose the buccal, we use the rule of 5s. In other words, when I'm designing my bone window in the mandibular anterior for a chin graft, a block graft, I'll go 5 millimeters below my root apices. I'll go 5 millimeters above the inferior border because you don't want to lift up your muscle down there. That's when you tend to get ptosis of the chin. And I'll stay 5 millimeters also anterior to our anterior loop of the mental foramen. I also like the piezo in the posterior for a ramus graft as well. I like the tips that they have, which allows me to do my superior cut, my lateral cut, and I like the tips that allow me to do that inferior cut as well. Okay, so one last question, and once again, if I didn't hit them all, please just DM me. And last question is, when you're doing your crestal lift, when you place your implants, how do you determine if you're going to place a cover screw or a gingival form or a healing abutment? Okay, so if I'm doing a crestal lift and I want to place my implant at the same time, what I'll do is that depending upon when I place my implant, the insertion torque, if I place the implant and it torques out greater than 25 Newton centimeters, I'll place a gingival form or a healing abutment at that time and do a 1-stage surgery. If I don't get that, if I get good stability, but I don't get that stability that I need, then at that point, I don't get the 25 Newton centimeters, I'll place a cover screw and then just close it up. And about 3 to 5 months later, depending if we do bone graft or not, I'll enter back in and I'll do that second stage. All right, so I want to thank everybody very, very much for taking the time. And I know we covered a lot of material today, and it's really an exciting field. Please, like I said, follow me on Instagram. I'll follow you back, and that's the way we exchange some information. And I want to thank you all very, very much because the comments that are coming through are really nice. So once again, have a good day today, and we'll talk to you all soon. Thank you very, very much.